a week or two ago, and I think we had some of this at the beginning as well. You know, every pathology course, of course, is a series of, it's a course, a teaching course where I present material to do. You hear things, you see things. Hopefully you read some of these things as well. But the very critical complement to a pathology course is the pathology lab, and specifically the histopathology lab. So because in the last two webinars, we were talking about nothing except tumors, tumors, tumors for 4 hours, we're going to spend this entire webinar today to show you many, many, many tumors, what they look like, and predominantly under the microscope, which of course is what pathologists do for a living every day. So if you can see, I selected about 20 cases here from our big microscope, digital microscope, and you are very, very lucky because in the old days, us poor students had to buy microscopes or rent them. Then we had to go to the lab, and we had to hope that it worked. We had to hope that nobody stole our microscope. We had to hope that the light bulb didn't burn out. But today you have the benefit of sitting here with me at my microscope on the other side of my microscope and looking at all of the features of all of the malignant tumors that we talked about. And what I decided to do is, even though we have like about 600 tumors or 600 slides in our slide box, I picked out 21, I think, of what I would call the most classical human tumors, the ones that are popular, the ones that are very serious. So actually, I could tell you what I picked out before we start looking at them. We got a lung tumor. We got several types of lung malignancies. Lung malignancies are generally classified primary lung diseases, primary lung cancers are classified into basically two types, what they call the small cell and the non-small cell. So we have some examples of each one. Then we're going to be talking about the most common malignancy in women, which is breast. Then we'll be talking about showing you slides from the most common malignancy in men, which if you hear, you know, is prostate. Then we'll be looking at the most common malignancy that is specific for both sexes, which is colon. And then we're going to do the kind of malignancies you could see without doing surgery or x-rays. Those are going to be the most common types of skin malignancies. And then in the second half, we're going to probably do what they call urothelial carcinomas, or carcinomas involving certain parts of the kidney, the ureter, the bladder, all because they are lined by epithelium that we call urothelium, or if you remember from histology, that's your transitional cell epithelium. Then we're going to be talking about the two types of tumors of the testicle. We're going to show you a germ cell tumor and a non-germ cell tumor. And then we're going to go to the other side, the ovary. We're going to show you a germ cell tumor, you know, tumors of the germ cells, and non-germ cell tumors. And finally, at the end, I have a few brain tumors I'm going to be showing you, which are the most common brain tumors. So that's basically what we'll be doing the whole day. And as soon as I click this camera down, I could click open my microscope, and I have selected all of the appropriate slides. So how about if we get going? And thanks for coming today. And also, I am very, very, very appreciative when I see your little comments in the box here in the corner of my computer that you can't see. So sometimes I may ask a question like, do you think this is a malignant cell? And you know, you may say something like yes or no, but don't be afraid, because if you're right, then you're going to feel really smart. And if you're wrong, guess what? You're going to learn something. So let's close down the ugly guy and let's show you the box of slides. You can see I have about 600 slides in my big box, and they're generally alphabetically and numerically ordered. And I decided to pick out 21, and we're going to put them now into our digital microscope. Now there is kind of a logical order to this. because I told you we're going to start out with lung tumors, lung malignancies. Most of the tumors we see here will be malignant tumors. Some will be benign, but we're going to be looking at features of the cells on the tumors that will help us determine whether they're benign or malignant. And sometimes you'll know exactly where we are at because you'll be seeing normal tissue in the background. I have decided not to show you normal histology again. We've gone through that twice already. And I will warn you, however, that if you have no experience with normal histology, which you should, because I'm giving this course at the second-year medical school level, but if you have no idea what a lung or an ovary or a breast should look like normally, you may have very big trouble today, although in some cases I'll have normal tissue next to the tumor or malignant tissue. So I was going to start with 4702, but I think it would be more logical if we start with lung tumors at slide B7. So if I'm not too sure if you can see all these little numbers, but here is B7. Just out of curiosity, can you see that I outlined that tiny little B7? Because if you can see it, that means that you're going to be able to see almost everything perfectly today, even the tiny nuclei, even nucleoli, okay? So we're going to start out with B7, and you don't know what B7 is, but I'm going to show you what B7 is. So here's our microscope, and as of right now, 2 seconds, you probably are looking at something that is kind of red and pink. And for those of you who have good recognition for histology, this little round circle here, and this one, and this one, and the one on top, and this one, and here. This is cartilage. It has the classical appearance of hyaline cartilage. Oh, I could zoom in, and I could show you and prove to you that it's cartilage. In fact, I think I'll do that. See that? Those are your chondrocytes inside their lacunae. But we're not interested in cartilage, normal cartilage tissue from bronchial cartilage. We want to look inside the bronchus. And what we see inside the bronchus, and you know this is a bronchus because it has cartilage. If it didn't have cartilage, you might call it a bronchiole. It's still a big, major part of the probably even perhaps a major bronchus, perhaps one of the branches of the trachea even. I don't know if it's right or left, but you do see here in the upper right, or what I'll call the northeast, that there are some little tiny little honeycomb spaces. You might recognize that instantly as being alveoli. In fact, if you don't, I'll zip it up for you anyway. So I'll make a little box. We've zoomed in. You can see small pulmonary arteries. You can see alveolar septae. You can see most of these small honeycomb spaces are alveoli. And it might not be the world's most normal alveolus because it's next to a tumor, but it's fairly normal. So let's go back down to the big picture and let's figure out why Dr. Minarsik happens to be showing us this particular slide. Well, the first thing that you might recognize, if you remember bronchus, it does not have a normal, smooth lumen. It has kind of a jagged lumen. And in addition, you can see that some parts of it look like there might even be hemorrhage. So you know that if there's a disease here in this lung and in this bronchus, it's going to involve basically the bronchial mucosa. So I'm going to take our little zoom here, and I'm going to blow this up. And I'm going to ask you, what do you see? And if you don't know, I'll help to tell you what you're seeing. What you're seeing is hemorrhage in the bronchial mucosa. Perhaps I can convince you that this part here is looks like squamous, but it also looks like the squamous areas are invading deeper into the submucosa connective tissue. So this is connective tissue here. These are squamous cells here, but these cells are actually invading. Now, I know what you're thinking right now. What you're thinking is, Well, why the hell should we have an invasive squamous process going on inside of a bronchus? Everybody knows the lung does not have normal squamous cells. The lung has pseudostratified ciliated columnar epithelium. So why should it have squamous cells? Well, you remember we talked about the process of metaplasia. This bronchus, perhaps for years, has been irritated, inflamed, and its epithelium has now changed from a pseudostratified ciliated columnar epithelium into an epithelium that is more conducive or more adaptive to the changes that it's undergoing. Look, here's a squamous nest. Here's some of the squamous nests going into the deeper tissue. Perhaps there's some remnant of columnar cells, but look, these are all squamous cells. And look, in some cases, they have invaded the underlying connective tissue, but they have stopped dead short of the cartilage. Does that mean that they're non-invasive? No, it means that they just haven't invaded the cartilage. But look at this. Some of these squamous cells have invaded the cartilage. So why am I showing you this first? I think you may have figured it out because lung carcinoma is the #1 most malignant tumor with the highest mortality in the United States, and squamous cell carcinoma is one of the most common types of lung carcinoma. Both squamous cell carcinoma and lung and adenocarcinoma are what we would call the non-small cell carcinomas. And you're probably wondering, why would you call it non-small cell carcinomas? Well, I'll tell you why. Because if you look at the cells, and I'm going to zoom in now on some of these squamous cells, they still have nuclei which are pretty big, okay? There is another variant of lung carcinoma, which is called small cell. So the squamous cell and the adeno and everything that doesn't have small cells might be called non-small cell carcinoma. Believe it or not, that's the most common type of primary lung malignancy. Now, they are much, much, much more common than the small cell carcinoma. But these small cell carcinomas are much, much, much more aggressive. They have a much, much, much higher mortality rate than the non-small cell carcinomas. Well, if there is any good news about the small cell carcinomas, we can probably say they may respond to chemotherapy more drastically. So we're going to leave this squamous cell carcinoma, and we're going to move on to the next slide. And because I have basically told you small cell, non-small cell, we're going to go to a cancer slide number 4702. And I think even though it's labeled 4702, you're probably going to figure out what it is. Bingo. You're looking at a lung again. And you can see that the lung has these alveoli. It's a spongy-like organ. Maybe you've seen a million of them, like me. Maybe you've only seen, a couple 100,000. Maybe you've only seen a couple. This is normal lung tissue. But look, right here along the pleura, you see collections of cells. And as I zoom in on these collections of cells, zoom in more, zoom in more, zoom in more, and zoom in more. And I'll zoom in even one more time. What if I told you that this is another malignancy of the lung? But look how tiny the nuclei are, relatively speaking, compared to the small cell. And also look to see that they don't really have much cytoplasm. That's why the small nuclei all look like they're crushed together, like a handful of oats. Oh, why did I say oats? It's not because Yulia just made me oatmeal. It's because this small cell carcinoma classically used to have the name oat cell carcinoma because they look like little oats. And maybe I'll even zoom in another time. Now, if you remember from the last several webinars, we said that the features of malignant cells is that the nucleus will look darker or hyperchromatic. These cells may look very much different from each other. Some may be bigger, some may be smaller. And in this particular one, you have all these features. Also, because oat cell carcinomas or small cell carcinomas grow very, very rapidly, and that's why they have a worse prognosis than the non-small cell carcinomas. That not only do they grow rapidly, they may even grow too rapidly to receive a proper blood supply, and therefore they may become necrotic. So here I'm going to move this thing a little bit more, and I'm going to show you something else, and I'm going to ask you a question. And maybe I could get some bold people. Look how big and dark and ugly that cell is compared to that cell. That's what you call extreme pleomorphism. In fact, once again, I could tell you, if one of my pathologist friends was over here and he was sitting in my chair, and he didn't know anything about this case, as soon as he sat down in my chair and he looked at that, he would say, oh yeah, that's malignant. He might not get it as oat cell, but he might, but it has all the nuclear features of malignancy. Now, I'm going to ask you another question because I'm going to go back to the big picture again. We were looking at this big lump. You could tell that it is subpleural, right? Because here's the pleural surface. But you could also see that the tumor cells are very, very rich in the subpleural space. Now, if you remember from histology, the subpleural space is also very, very rich in lymphatics. So this tumor has extensively involved the subpleural lymphatics. And I hope you understand that because I'm going to ask you a question now. And it just requires a one-word answer. Because this highly malignant small cell carcinoma is underneath the pleura, where it is very rich in lymphatics, do you think that the tumor here in the pleura originated there? Or do you think it metastasized to the subpleural lymphatics? So the question is, did it originate or is it metastatic? You have to put one word, origin or metastatic. And you're not going home until I get up. Yeah, and everybody's gotten the right answer, which means maybe I explained it properly. So let's move on to the next case. Thank you for getting the right answers. But you know what? I love to see wrong answers because then I feel like I'm actually teaching somebody. Okay, I think we're going to close it and go on to a third number, which is going to be called B26. It sounds like a bingo game, doesn't it? So here we go. B26 is right here. You could probably see the B26. And here we are. It's under the microscope now. And you're looking at something that is not only pinkish blue, like everything in histology is, but I think you could see that this is also lung tissue because you could see alveoli up here. And if you want me to prove it, once again, I'll show you the alveoli. So you can recognize this as lung tissue almost instantly. There's an alveolar septa. There's even some capillaries within the septa. There's some larger vessels. There's the alveolar spaces, and maybe that's like a terminal bronchiole or something. You remember all those terms from histology. So let's go back to the big picture, and I'm going to ask you something about this big density within the lung. And why do I call it a density? Because it's not, doesn't have air. It's all cells. It's all tissue. The radiologist might also use the word density because it is blocking X-rays much more than the normal lung, which doesn't block much X-rays because it's air, okay, or CT. But before I go in and show you the cells that are comprising this irregular density, can you see that this density is not very, very well delineated from the lung? It's jagged, it's irregular. It looks like the claws of a crab. Hey, what is the Latin word for crab? The Latin word for crab is cancer, isn't it? So here we are. We got an irregular density that is not very well separated from the lung of which it is residing in. So by definition, that makes it invasive. And if you don't believe it's invasive, then let's use the microscope. And bingo, we can see lung hair on top. We can see part of the density, the invasive, poorly separated density towards the bottom. And I'm going to ask you, I hope, an easy question. Look at this nest of cells here. Look at this nest of cells here. Look at this nest of cells here. I'm going to ask you one simple question. This nest of cells here, does it look like they are arranged in little circular clusters? Yes or no? What else is arranged in circular clusters? Glands. So here's the question. Is this an adenocarcinoma? Of course it is, because these look like little glands. Even though they're not growing regularly, they are little glands, and they're not arranged like the solid clusters that we saw with the squamous cell. So this is an adenocarcinoma of the lung. Hey, and what is all this stuff just to the north and west of it? They're lymphocytes. So it means that this tumor is actually interacting with these lymphocytes. If you remember, the CD8 effector or killer lymphocytes are the ones that usually form the immune reaction, and very often in malignancies, the more lymphocytes you see surrounding or attacking the tumor cells, the better the prognosis is, generally speaking. But here, let's even zip on it a little bit higher, and we're going to definitely show you these little glands. Do you see how prominent that nucleolus is? Do you see how irregular it is? Do you see how some of them are big, some of them are little? But look, there's a bunch of little lymphocytes trying to kill those malignant cells. But they may be successful to a certain degree, but there's a lot of tumor present, isn't there? So these tumor cells are not small like the lymphocytes, so you can't call it a small cell, and they are arranged in little clusters or glands, which maybe you can see better if I go down another notch. Like here's a little gland, here's an irregular, or what they might call an abortive gland or a poorly formed gland. So this is the other type of non-small cell carcinoma of the lung. It's called adenocarcinoma. Now, because it's glandular. Now, when I was a medical student, we were told that the squamous cell carcinomas, which arise from metaplastic large bronchial epithelium, which are in the center of the lung, would be more centrally located. The mass would be more centrally located. So the radiologist will tell you that the squamous cell carcinomas arising from metaplastic large bronchi would be more likely to be centrally located, and the adenocarcinomas generally are more peripherally located as a general rule. But in this case, we have an adenocarcinoma in the lung. Now I'm going to ask you the number one most important question right now, if you haven't figured it out yet. We have a lung, and we have an invasive adenocarcinoma in the lung. Here's the question. Did this adenocarcinoma start in the lung, or is it metastatic to the lung? And I'm going to give you three choices. It started, it's metastatic, or we don't know. Those are the three choices. And what's your answer? Well, the first few people are saying the correct answer. We don't know. Now, you don't know. All you know is that could it be metastatic from the breast? Could it be metastatic from the prostate? Could it be metastatic from a salivary gland? Could it be metastatic from it could be metastatic from any primary glandular adenocarcinoma. All we know is that it's in the lung. So if you were a smart pathologist and you saw this, you would say adenocarcinoma in the lung rather than adenocarcinoma of the lung. Now, if the patient had not had any other known primary cancers, you might tend to think that this was primary rather than metastatic. However, if you stained some of those cells for antigens that are specific for prostate or pancreas or breast, then you would know it was metastatic to the lung. But for all practical purposes, the proper term for this particular lung non-small cell adenocarcinoma malignancy would be adenocarcinoma in the lung. Okay, I think we're doing pretty good. Let's go to the next one. Well, let's see, we got this. Oh yeah, let me show you a really, really nice case. It's going to be called B30. And B30 is right here. And remember, this course is not intended for experienced pathologists. This course is intended for medical students who have had a basic familiarity with histology and perhaps a growing familiarity with pathology. Well, we don't know what this is over here on the left, but it looks like it's some kind of connective tissue. And then you got some big nodule here on most of the right side of it. But let's zoom in on this particular left side on the west coast. And let's see if we could figure out where the hell we are. Well, I'm going to just zoom in here. And what do you think these glands might be? Do they look like they're arranged normally in little clusters? You might call that a lobule. You might call that a lobule. You might call this maybe one lobule or perhaps a big lobule or a couple lobules close together. This is a normal breast. Remember, we might not be showing you normal histology today, but in this particular part of the slide, we have a normal breast tissue histology. But right next to it, there is something that does not look like normal breast. Oh, it has connective tissue, fibrous connective tissue, and it has these large glandular spaces. But look, can I ask you a question? Is this tumor here well separated from the normal breast? Microscopically? I need a yes or a no. Yeah, yes, thank you. Not only is it well separated, but you might even imagine that this fibrous tissue acts as kind of a capsule. So we have a very well delineated tumor in the breast, and it's almost very well defined. It's a sharp margin. It does not invade. So let me ask you this. Even if you don't know what it's called, would you think perhaps this is a benign tumor or a malignant tumor? Yeah, benign. In fact, what if I told you that she was that this woman was young, perhaps in her 20s even, or 30s, and not in the usual older age group of breast carcinoma, which is 50s and 60s and so forth? This is the most common breast tumor that's benign of young women. Does anybody want to act like a real smart person and give me the name already? Or do you want me to give you the name by describing it histologically? Okay, well, nobody wants to venture that out. So let's see if we could name it by virtue of what it looks like. So we are going to blow it up in the area we were in before. Do you notice it has both fibrous or connective tissue component, which is abundant, but then it has a good amount of these little glandular spaces, okay? or little tiny adenoma spaces. So what would you call a tumor that is fibro, but it also has adenomas or adenos? This is a benign fibroadenoma. It is the most common solid tumor of young women. If it was a cystic tumor, you would probably think it was fibrocystic disease. But this is the world's most... By the way, I don't know if you've ever seen a fibroadenoma on mammography or in the operating room or in the pathology lab, but they have the exact same consistency as a super ball. So I bet you if you really talk to most pathologists, they will probably tell you that at one time in their life, they probably bounced a super ball on the floor of the pathology lab. But, you know, they probably won't admit it to you because it makes them sound unprofessional. But I'll admit it to you, I have, only to demonstrate the bounciness because of all this connective tissue and its extreme circular delineation as well. This most common benign breast tumor of younger women. Now we're still on breast, and I have a number here that's called AACR Fem06. So we go to the A's, which is going to be around here, and here it is. And once again, this may have been a density on mammogram. It may have been palpable. It may have caused nipple retraction. It may have caused perhaps a bleeding from the nipple. But probably most of these are picked up nowadays by either mammography or perhaps palpation. This is a mass in the breast, and you're looking at it microscopically. And yeah, you could see connective tissue down here, especially at the bottom. And yeah, and you can see some type of irregular glandular formation in the upper and left side of the picture. But let's look at it under the microscope, and that's why we have microscopes, so we could see things better. So you see these irregular dark glands here? Are they well separated from this fibrous tissue, or are they sending out these little streams of cells into it, tiny glands? Some of them look linear, some of them look haphazardly circular. So even if you don't know anything, let me ask you, do you think this is a benign or a malignant tumor? Even before you look at the nuclei. Yeah, you know this is malignant. So let's blow it up even more. And we're going to get something like that. And look, there's clusters of irregular glands. They're not quite as circular as what we saw in the other one, in the lung. Some of them look linear, but in some areas they look kind of circular. But it seems like the nests that are infiltrating the most are not quite as circular as the ones that we see in this area. I think you could appreciate the fact now that many of these little clusters look kind of circular, but they're very poorly circular. But as they stream off into the connective tissue, they are looking less differentiated or less circular than what may have been the primary tumor. Now, let me tell you something we've said before, but we'll say it again. Many cancers, especially adenocarcinomas, but many cancers, when they invade into the surrounding fibrous connective tissue, they evoke what they call a desmoplastic or a scirrhous response. So most of the classical ductal carcinomas of the breast, which this is, were also called scirrhous carcinomas, and they still are. Now, what does that mean? It means that not only are these glands invading the fibrous tissue, but they are also evoking the process of more fibroblastic production of collagen. Okay? So I think even if you don't know what organ we're talking about, or where we are, or what the x-ray shows, probably if you saw these little nests of what look like glandular or at least epithelial cells inside of evoking an irregular connective tissue response invading the fibrous tissue, you would probably think this is probably a carcinoma. And because there's so much of a fibrous response to it, probably the two types of cancers which evoke the most fibrous responses are also happen to be the two most common sex-specific cancers, which means in a woman, breast, in a man, prostate. Okay, let's see if we want to show you any more breast, or whether I should surprise you. I'm looking at my next case here. I'm going to show you something. It's called, I don't think I could read it too well. Is that a 9 or a G? PaO3. Well, maybe we'll have to search for it. I know what it says. It's AACR. That's what it is. AACR PaO3, which is going to be right about here. And here we are under the microscope again. And once again, you can see something towards the bottom that looks more like lighter fibroblastic collagenous connective tissue. And towards the top, you could see something that looks bluer, but it also may have some open spaces like we saw so many times with glandular malignancies or glandular tissue even. And we're going to zoom in on it a little bit more. And I can tell from doing many years of experiments that usually about 1 second after I see the slide on my microscope, you can see it on yours. But I have to be careful. I have to talk a little bit slower than I show the slides. Otherwise, you're going to think that I'm lagging behind. So here, I'm going to ask you a question. I'm going to blow up this area here. And as soon as you see it, this area blown up higher on your screen, I want you to just say yes. And I'm guessing you most of the yeses that I see will be about 2 seconds from when I see it. So I'm going to go. Remember, as soon as you see something change on your screen, please say yes. So yeah, it's about 2 seconds. Now you can see glands, and you could see that they're irregular, and they're not have the normal secretions like prostate glands should have. What else can we say about it? You can also say that the vast, or many, or half at least, of these cells have prominent nucleoli, like you see there, and 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 almost, it seems like almost every cell, or at least every other cell, has a prominent nucleolus. And you can also see that in some cases the glands are growing right next to each other rather than being separated by fibrous tissue. And you can also see the fact that many of these nuclei are not at the base of the cell, like they should be if it's secreting material. Some of them are coming almost all the way up to the apex of the cell, or what we call loss of polarity. So, ladies and gentlemen, if I told you this was normal prostate, you should not believe me, because the glands are irregular, the cells have nucleoli, they're not arranged properly. Here's one that's undergoing a mitotic division. Here's another one that's undergoing a mitotic division. Some are real dark, some are light. So I think you would say right away that if this came from a prostate, it's probably an adenocarcinoma. And it is an adenocarcinoma. Now, I would ask you the question, is this an easy diagnosis or is this a hard diagnosis? Well, if the adenocarcinoma looked a lot like normal prostate tissue, you would say, Well, it's a hard diagnosis because I'm not even sure it's malignant. Then you would say that this is a well-differentiated adenocarcinoma, and it would be what you might call a Gleason 3. If you go from 1 to 5, this might be a Gleason 3, where 1 is the best, 5 is the worst. But if you say instantly, oh, this doesn't even look like glands, this is terrible, this is malignant, it's an easy diagnosis, but it's a very bad tumor because it's poorly differentiated, maybe a Gleason's 5. Then you would give that the 5 number. Now, I'm not going to go into all the Gleason's classification, but very simply, the lower the Gleason number, like a 1, means the most well-differentiated the tumor is, and the more it looks like normal prostate, and therefore it's hard to diagnose. If it's a Gleason's 5, however, it is very easy to diagnose because it does not look at all like normal prostate tissue. Now, I can tell you, I looked at the answer from this slide because it was given to me by the University of Iowa, and they called it a Gleason 3. So that's why I'm showing you the Gleason 3, because it's intermediate. Now we're going to go back down again to the big picture. But let's say you had a hard time diagnosing this thing. You don't think, oh, I don't know if it's cancer or not. I see some funny glands. Or maybe what they call PIN, which are dysplastic changes which may precede cancer. But let's say you now look at the capsule of the prostate. And the reason why that's very black there is because when the surgeon removes it, he then gives it to the pathologist, and the pathologist puts India ink on it to make sure that the tumor cells don't go to his surgical margin. So if these cells here went to the surgical margins, he would know that the surgeon did not get it all. That's the general thing. So the best thing that a surgeon likes to tell a patient after surgery is, we got it all. And then that patient feels like he has a new lease on life. But let's say that this was a very, very difficult case to diagnose because it was very well differentiated. And you got a bunch of pathologists looking at it, and some of them saying, well, I think it's benign, or, oh, I think it's malignant. Oh, I don't know. And believe me, this happens all the time. I'm going to show you something right here, a tiny little area which you're probably not even aware of. And I'm going to ask you a question. What is this little circular structure here? Do you remember from histology? This is a nerve. So, what would you call a glandular process that actually surrounds the nerve space? Do normal glands invade the perineural space, or do only malignant glands invade the perineural space? Yeah, so you know, you don't have to debate anymore to prove that you're smarter than your fellow resident or attending. You know that if these glands actually invade, here's the nerve, and you can see a little glandular cluster here, and you can perhaps seeing some come in here. You know then that this is malignant. But of course, this was a Gleason's 3, so it wasn't difficult to diagnose at all. And I'll tell you one other tip. And I don't know if you want to remember it or not. You probably don't have to know it for the step exam. But the number one characteristic of malignant prostate glandular cells is that they all, or many, 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 have prominent nucleoli. Not nuclei, but nucleoli. So a normal prostate, you might hardly see any nucleoli inside the nuclei. But in prostate cancer, even the ones that are hard to diagnose, many of them, perhaps more than half of them, have prominent nucleoli. That's one feature of prostate cancer more than any other cancer. So I'm going to close this down, and I'm going to look at my watch. And I think I want to show a couple more cases, but I've been kind of getting carried away. And oh yeah, we'll show you another case or two. And then we'll have Yulia play us more music in about 5 minutes. and she's putting her face into her hands. She looks nervous, like she's never played the piano before, but actually she's played it her whole life. And so did her mother. She's a piano virtuoso. Okay, we're going to show you O22. And let's find O22. So we go where the O's are. Here's the K's. Here's the S's, so the O's got to be in between. Here's O22. You probably have no idea what it is, and I hope it's the one that I think it is. Oh, no, that's not it. I'm sorry, I got the wrong slide there. I had N22. Here's O22. Okay, now for those of you who even had a primitive recollection of histology, you already know this is part of the gastrointestinal system. And furthermore, you know that these little crypts in the mucosa make this so characteristic of large bowel rather than small bowel. And then you can see perhaps some looser submucosal connective tissue. Then you see the thing that is the greatest thickness and actually gives the wall the